official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Wynn. We will also examine proactive approaches to cancer prevention and, most importantly, how we are breaking barriers to beat cancer in our community and beyond. Today we're talking with Dr. Lara Fejerman, who wears a lot of hats at the Cancer Center. She is the Placer Breast Cancer Endowed Chair, the Associate Director for the Office of Community Outreach and Engagement. She is also the co-director for both the Women's Cancer Care Research Program and the Latinos United for Cancer Health Advancement Initiative. Welcome, Dr. Fejerman.
Thank you for having me.
We'll be discussing her work with the community and how her programs help to reduce the cancer burden in underserved communities. And let's start with your Historia, Cuenta program. Tell us about it. It's pretty innovative, and we're so excited that you brought it to this area.
Yes, the Historia Cuenta, or Your Story Counts, it's an attempt to increase genetic counseling and genetic testing for hereditary breast and ovarian cancer for women who are Spanish-speaking mainly, and is based on the observation that Latinas in the U.S. are 4 times less likely to get genetic testing. And we wanted to address the difficulties that those who are not fluent in English and have more limited materials based on that they can use to make decisions, that they would have the information and also the support to access genetic counseling and testing if needed, based on their family history.
And how do you do this exactly? What makes us unique?
Well, we use a continuous stakeholder engagement approach, meaning we develop all our materials working together with community. And when I say community, it means what we call the promotores, so community health educators, that are specific for the Latino community. And we also work with members of the community. And each aspect of the material had a process where we would prepare a draft set, then have a focus group discussion, get insights that we can feed into the materials and adapt them until we had the perfect educational materials based on all this feedback.
Well, you mentioned the promotores, and what can you tell us a little bit about their role, like what type of background or education they might have, and then why they are so important to the Historia Cuenta program?
We know already, this is evidence-based in the sense that there's been previous work showing that promotores, or community health educators for the Latino community, create this liaison between the medical system and the community. These communities tend to be underinsured or lack insured, have a mistrust, or are scared of being identified as undocumented immigrants. There's many issues that make them less likely to use screening services, for example, for breast or other cancer screenings. And the promotores are actually part of that population. For example, most of the promotores, if not all, in my program are monolingual or limited Spanish speakers or limited English speakers. They are the people we're reaching out to. And we just work with them to train them so they would be able to communicate about genetic risk, which is such a complex topic, to their communities, because they are trusted mediators. And hence the success of the program, as the promotores use their own networks to talk to people that knew them and trusted them, to bring them into our education and risk identification program.
Well, that's wonderful that they're the safe space that you can use to help benefit the community that is so underserved. How are the promotores selected?
So we did these trainings, and very keep in mind we planned everything before COVID, and at the time that we finished our training, our first part of the training for promotores, the pandemic started, and so we had to retrain all the promotores to be able to educate the community online. We actually wrote a paper, an article with the promotores about their experience. So it's a paper we wrote together about their experience going from being a community health educator, showing up in church or at schools in person, to being an online educator, which is a totally different animal altogether.
What an opportunity for these women to make a difference in their own community. And they're being paid, correct? So
Yes.
we are supporting a whole new workforce out there, really.
Yeah. Now I go back to the question of how we hire them, how we chose or selected the promotores, which is what was asked, and is we train 30 something. I think there were a total of 34 promotores. Partly in person, and partly we did the supplementary training for the virtual version. And we were working with two community-based organizations that actually train and hire promotores. So one is Visión y Compromiso, the other one is Promoters for Better Health. And they have slightly different models of how they work with promotores, which also was very interesting. One is more... they hire the promotores, and there's a general supervisor, but the promotores work quite independently once they are assigned to a certain region, and they do most of the communication with the research group as well as with the community. The other model is more centralized. There's one person who does the communication with us and with the participants, and their promotores just show up for the 1 hour education session. So they are less involved in the follow-up aspect of the program, or even the registration process and all that. And both programs, both models work really well, but it meant like we had to adjust to having, these community-based organizations and how they felt comfortable working, which was really interesting. So we trained them, and basically then we delegated the hiring process and selection to these organizations, and it was based on shared criteria about what we were looking for. Someone who this genetic content is not easy for anyone, and so we wanted someone who felt comfortable. So they talked to them, and as we saw them practicing as well, we could tell the level of comfort and how well it was gonna go. We got an excellent group, worked for about 4 years and did an amazing job. And I'm still working with one of the promotores from Visión y Compromiso on an expansion of the program to Yolo County.
And if someone wants to get involved, if someone would like to become a promotore, how do they go about it?
So usually there's these organizations that train them, they even certify them. Visión y Compromiso has multiple modules that you can go through that give you it's like knowing what a promotor is, knowing what things you do and what things you don't do, what type of advice you should give, and how to talk to community. It's really there's also the peer mentoring aspect. So most of the training is done by people with experience as community health educators. And so if you go to one of these organizations, they can train you and then connect you with projects like mine.
So do you, like in long term, do you see this network that you're growing through partnerships, growing like to cover the entire state of California? Or is this something that you're trying to focus on just in smaller areas throughout the state?
Visión y Compromiso, I keep bringing them up because they are a wide network. So they have a network of about 5,000 promotores.
Whoa.
So working with them in California allows you to basically connect with someone almost in every region you're interested in California. But I also Promoters for Better Health. It's more local. It's in they are set in Pomona in Los Angeles, but again with the virtual opportunities, they could also provide education everywhere else and kind of build the networks. They kind of know what to do. So if they were working in a different region, they would build those networks in no time because they know that the churches they need to go to, and they know there's this, the Latino parents in the schools that you can reach out to. Actually, the Maria, the promotora who's working now in Yolo County, is from Sacramento, but she's already building through the network of schools her platform for educating Yolo community members.
So she as an example of all of them, have just a really great depth and reach into their respective communities, so that
Right.
they can quickly and effectively build levels of trust, and then also expand the information in your studies. Correct?
Yes, and there's a network of promotores now because this figure is becoming more and more. There's more and more evidence. People agree that we need this figure. We need the promotor to connect with these communities, and so they also have a network between themselves. They've done similar trainings. So if you are not in this region, you still know someone maybe who's working in that region. We, for example, work with Maria a lot when we are doing other programs. We have we've been working on cervical cancer and HPV infection-related cancers, and Maria is helping us when we're developing the materials. She helps us get promotores into focus groups so we can get feedback on those materials. So it's what's fantastic about promotores is this relationship building aspect that they have as part of their nature. Usually a promotor is a very social person who builds relationships. That's part of their quality.
Okay, so as Stephanie had mentioned earlier, you wear many different hats within the Cancer Center, and so you are the co-director of both the Cancer Center's Latinos United for Cancer Health Advancement Initiative, or LUCHA, and then Women's Cancer Care and Research Program, or We Care. And so, can you tell us some of the goals of improving health outcomes for the underserved communities, and how do those goals that you're trying to reach intersect with the use of the promotores?
Every project we work on that it's related to cancer screening in the community or improving awareness, self-advocacy, whatever we work trying to do, especially from the perspective of community outreach and engagement, we end up working with promotores. And we do have a figure in the Cancer Center, which is we have community health, we have health educators, and a lot of the work we do, for example, in the Office of Community Outreach and Engagement, and even Lucha, is work with our community health educators, who are slightly different than the promotores we work with on these projects that I mentioned, in the sense that they tend to be people who are interested in public health and in educating our communities. We do have people with different language competencies that we can kind of leverage their language competencies to educate non-English speaking communities, but they are slightly different profile. And so we do a mixture of those educators who are very passionate and also very effective, but together with these networks of promotores, whenever we're working with the Latino community, because they are the ones who can help us first understand how to approach the community, And second, to create those relationships that we need to bring the educational materials to the community. And the thing is, our cancer center has our catchment area that we call, so the area where we have a lot of our patients and we're trying to address the cancer burden, has a high proportion of Hispanic Latino individuals. So a lot of our programs are connecting us to them through the promotores, either as advisors on how to develop the materials or as active educators. And one interesting project that we're working on now is partnering with federally qualified health clinics, but we help them incorporate the promotor model into the way they reach out to the clinic population and the way they do education. So they can increase screening, reduce the no-shows, which is an issue with all these community clinics where people get scheduled for an appointment, but they don't show up, either because they don't know how important it is yet, and so they don't have that motivation, or because of other barriers that we're trying to address. But we are doing a clinic version of Tu Historia Cuenta. This is with support from Gilead Corporation. Actually, they have a oncology health equity type of award, and is adapting our community-based Tu Historia Cuenta program to the clinic setting, which has been very interesting, and has its challenges. But we think that once we figure out how to make it effective in this setting, it'll be more sustainable than the efforts we're doing outside the clinic setting.
And what about our plans for our own mammo van? Will that be easier, do you think, in terms of making sure it's accessible, that these screenings are accessible?
Yeah, we're very excited that our own mammo van, which is beautiful, by the way, is coming in July, hopefully. And we are working really hard. Our program manager has put a lot of effort on figuring out how to make sure it does what we want it to do. We want it to go to the community, but also be sustainable in the long run, because many of these programs are hard to sustain if you want them not to depend on external funding. And so we're designing what I call like a combo service, where you serve some people who have private insurance, which unluckily pays higher rates, and so are more helpful to sustain the program. But then you can kind of leverage the funding you get through the private insurance to serve those who are underinsured, and so either they are not able to pay at all, or because they can't afford the copays, or because the program that they are being insured through doesn't pay the same rate as the private insurance. So we're balancing all that. Also, we have ideas of working with companies to bring the mobile mammo van to the employees, and have this business model where you're really serving the community, but at the same time, you're not gonna be there for 2 years and then have to retire the van because it's not sustainable. And so once figuring this out is really important, because then I think if we manage and we are able to be there for the long run and do the follow-up for the woman that we start serving, we'll be able to change the landscape of stage at diagnosis for breast cancer. But I think we need years of providing these regular annual mammographies to the people who, without having the van in their backyard, they would not show up and they would not do this every year.
And obviously, when we catch breast cancer early, it is less costly to treat, right? Whether you're on Medi-Cal or privately insured, and the outcomes are going to be much more successful. So the key is spotting that cancer early, correct?
Correct. And I keep reminding everyone it's not just about reducing mortality, which is one of the kind of hard measures we use to show that this is effective or not, because it's changing mortality rates for the disease. I think detecting breast cancer early changes the quality of life of the person, not just the risk of dying of the disease. If you detect the disease early, the level of treatment and intervention that you need is a lot more bearable than if you have to deal with treating advanced cancer. Even if we could keep you alive for a long time, it's kind of more traumatic. And so I want to add to the cost effectiveness calculation this quality of life component. When we're detecting earlier the cancers, are we also improving quality of life?
Do you anticipate seeing generational change as these programs just continue to work within the communities? I know this has been just a focused program over just the last handful of years, and so you're not going to see all kinds of evidence. But have you begun to see some evidence of families or extended families beginning to open up a little bit, or to gain access, or to seek out screenings and then pass that along, maybe from mother to daughter or grandmother to mother to daughter, anything like that?
That's what you would hope. I think it's really hard to see in a short period of time. We're still trying to get people to do the genetic testing. There's a lot of issues with fear, there's hesitation, as well as the difficulties of just the logistics of getting people who might not have access to technology to activate the genetic testing kits that we send them. I'm hoping that we'll see changes if we can. I think we need. That's why I was saying the sustainability of the mobile mammography program. I think none of these programs will show their impact in the short term. I think we need to be able to sustain these programs. This is my main concern. So we can actually change the culture, as you were saying. The more we are active, the more people we can reach. And we can start creating that base of shared knowledge. Only happens with larger numbers.
What types of resources do you need, or are you looking for, to help that sustainability?
It's a good question. I'm trying to continue the testing aspect of it, and that tends to be costly because when you want to do, for example, a randomized design for your intervention in a large, with a lot of sites involved, because that's what you need to demonstrate the effect of your intervention, that tends to be really costly. It's not the same as just like sharing materials with the clinic and saying just do the education and if you want everything in place to be able to measure the impact of your program and to really assess how this material makes it better than this other material. I think one of our next steps is to try to do a randomized clinical trial design with the Historia Cuenta program in the clinic setting, once we figure out what's the perfect combination of materials and support that the clinics would need. And that funding is different. For example, for the mobile mammography, we are trying to get support that would sustain it. Say, imagine from the state, where they would hopefully see mobile mammography as a service to all the state population, and they would be willing to just sustain it with a contribution that maybe helps have it more time in the community. Because as I was saying, we're balancing community time with time within care settings where people are, have more private insurance. And if we get extra support, then we can increase our community time.
Is there anything else that we have not covered today that maybe you would like to point out or bring up or discuss?
One thing to add is if there's a community organization that is interested in educational programs or even support for navigation related to cancer screening in underserved communities, the Cancer Center Office of Community Outreach and Engagement would be delighted to partner, create new relationships, and listen to their needs to be able to support them and work together towards solutions for their particular communities. They can reach us. You can look at my personal email. I can share it, or you can share it through the. But I'll be happy to have people contact me, or maybe contact you if they are interested.
Absolutely. And we'll put links in the description for the Office of Community Outreach and Engagement, and also links to the Women's Cancer Care and Research Program, Lucha,
yes.
Everything like this, so that, anybody that has any questions or anything regarding any of the topics that we've talked about, they can have access to some information. Also, to one of the Promotores articles that it's in our Synthesis magazine that Stephanie wrote, which is outstanding. So we'll link all of that in the description. Thank you, Dr. Fejerman, for joining us today. This has been a great conversation.
Yeah, just a pleasure to talk to you and just listen to all the great work you're doing, you and your team.
And thank you for giving me the opportunity to share.
Absolutely. Well, thank you for tuning in and listening today. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.